In this speak, I will talk about the universal FH screening program in Slovenia. So Slovenia is currently one of the very few countries with kind of universal nationwide program, and there are a few pilot universal programs existing, for example, in Czech Republic, Slovakia, or a few institutional based or regional universal screening programs. Most of them are also on a pilot basis. Slovenia is a small country in Central Europe with 2 million people. It has around 20,000 newborns annually and 2 university medical centers. We have a network of around 500 pediatricians and a strong primary care pediatricians association. And in addition, we have one pediatric lipid clinic and one lipid genetic lab. Both are at the University Children's Hospital, Ljubljana. In Slovenia, as legally required, there are frequent program preventive visits at primary pediatricians. So typically, child by the age of 5 years would see his or her pediatrician for 10 times, which is also the basis for cholesterol measurement at the age of 5. So we have a 3-step approach of FH screening. The first step is universal cholesterol screening at the primary care level. The second step is genetic FH screening at the tertiary level. And the third step is child parent screening at the tertiary level. We have a detailed screening algorithm which allows to specifically address all the situations within this screening program. As a first step, there is a universal total cholesterol measurement at the primary care pediatricians at the age of 5 years. This is prior to entry to school. If the total cholesterol is above 5 millimoles per liter, retesting is ordered. If the total cholesterol is about 6 millimoles per liter or about 5 millimoles per liter plus positive family history, the child is referred to the tertiary lipid clinic. This algorithm is also detailed and available to all the primary care algorithm to act in a same fashion. So the frequency distribution of cholesterol levels in our population shows a long tail on the right side, where most of the heterozygous FH patients are concentrated, but there is also a relatively substantial overlap between heterozygous FH and polygenic hypercholesterolemia, and these cases are also detected by our screening program. In 2014, a pilot assessment was performed and showed that over 91% of 5-year-olds had actually tested total cholesterol, and 0.7% of them had total cholesterol levels above 6 millimoles per liter. As a second step, we have a genetic FH screening at our lipid clinic at the University Children's Hospital, Ljubljana. We assembled a NGS panel comprised of 3 FH genes plus 15 other genes. And by our program, we thus detect also different types of rare dyslipidemias, which are associated with elevated cholesterol. We published before some analysis from the program in recent years. First showed that over 50% of all referred patients had confirmed FH, but in more recent years, this percentage is around 40 or 45% due to higher referral rate. And then we have also a bit more of FH negative patients referred. But up to mid-2021, we altogether performed over 1,500 genetic analyses, and approximately 1 in 400 of total yearly birth cohort of children are confirmed FH, either genetically or clinically. So there is a quite big overlap between the FH positive cases and FH negative cases. And also our population has quite a lot of ApoB positive patients. But on the whole, we have, with a population of 2 million people, around 220 FH positive kids in our pediatric registry per 1 million. The sensitivity of LDL 3.5 millimoles per liter threshold is 85.2% and specificity 61.1%, which means that there is actually also quite substantial detection of polygenic cases if we want to detect majority of monogenic cases. As a third step, we have a child parent, which is also called reverse cascade screening. So each child has one parent with FH, which was confirmed in 94% of children in our cohort, and 3/4 of the parents were not on the therapy, and most of them didn't know that they have elevated cholesterol. Direct costs of the program were around 850 euros per one genetically confirmed FH patient detected. To conclude, Slovenian model of universal FH screening, which is three-step approach, is feasible in practice. We confirmed FH in approximately 1 in every 400 children born in Slovenia in the recent years. To have a fully functional program, it's important to establish a national or regional reference pediatric lipid clinic and also referral genetics lab. Very important is a good collaboration with primary care level, especially with primary care pediatricians, but also in some systems, GPs. Important is to establish FH registry and to support patient initiatives. And also important is a good transitioning care, so good collaboration with adult physicians, not to lose the many benefits with early screening. By doing universal type of screening, you also detect many polygenic, hypercholesterolemia patients, and some secondary disorders. And every screening program needs to be prepared to that. So thanks a lot for your attention. As a next speaker, I would like to introduce Professor Albert Wigman from Amsterdam. Albert doesn't need special introduction. He's one of the giants in the field and actually directly responsible that many children are diagnosed and treated in time.